So MRD is obviously a very important prognostic indicator in AML. This has been shown in multiple studies as well as in a large meta-analysis that showed very clearly that achievement of MRD negativity is associated with better clinical outcomes, disease-free survival, and overall survival in patients with AML. I think there's still a lot of controversy in terms of what is the appropriate MRD marker that we should be using. Do we use flow cytometry? There are certain situations, for example, where we use PCR. So for those patients with core binding factor leukemias, we use PCR for the inversion 16 or the translocation 821 transcripts. At many centers, you can use PCR for NPM1 mutations for those patients who have NPM1 mutated AML. And then for those patients who don't have a targetable mutation or transcript, we use flow cytometry. So we know very clearly that this has prognostic implications, but the question is, how do we use this therapeutically? I think we see that even in the quote-unquote favorable risk leukemia, such as the core binding factor leukemias, those patients who have persistent MRD can unfortunately still have relatively poor outcomes, and so we do recommend those patients for transplant. So this is one area, for example, where we use the MRD information to make therapeutic decisions, such as sending patients to transplant. For patients with adverse risk disease based on cytomolecular features, we of course look at the MRD. It has some prognostic implications, but those patients we're still going to send to transplant regardless of MRD status. It's really most important for those patients with intermediate risk AML. Those are patients where we're often on the fence. It's an individualized decision about whether or not those patients should be sent to transplant, and MRD can really help. Those patients who achieve MRD negativity, many of them can do very well without transplant. Certainly a patient who has persistent MRD should be referred to transplant or get more aggressive therapies. We've also seen for patients who have MRD relapse, so patients who achieve MRD negativity and then eventually, or at some point later, we see that the MRD is starting to recur. We have seen in retrospective studies the importance of intervening. That can either be with changing therapy, changing to another chemotherapy-free another chemo regimen, or sending them to transplant. So we are using this information. It's still controversial how to integrate all of the different MRD measures that we have, but we are using this in some ways to decide on transplant. And also importantly, I think for our patients is to enroll these patients on clinical trials. There are a number of MRD-directed clinical trials at our institution and others, and I think it's very important that patients are evaluated for these studies because we really want a drug, for example, like we have blinatumomab in ALL, we're trying to find the similar drug in AML so that we can eradicate MRD for these patients, improve their outcomes, and maybe in the future, patients with who have MRD positive AML can be treated with whatever this drug is and then may not actually need transplant, which is of course the current standard of care for patients with MRD positive AML.